Good evening, everybody, and welcome to our weekly cerebrovascular and skull-based symposium at University of Miami. It's a very special day because it is actually the last one in a series of 30. Please stay tuned, and we probably will restart them perhaps at one a month. But this is the last one in a series, and certainly, as you will tell, one of the best ones you would have seen. So December 17, today, session 30. I'm Misra-Morcos, a professor and co-chair in neurosurgery, and I direct cerebrovascular and skull-based surgery here at University of Miami. I'm very thankful to my co-directors, Carolina Benjamin, who's assistant professor, who directs our Keynes dissection lab. Carolina specializes in brain tumor and skull-based surgery, as well as Michael Ivan, who directs our research, UM Brain Tumor Initiative. Mike specializes in brain tumor, skull-based, and epilepsy surgery, as well as Bobby Stark and Eric Peterson, co-directors of endovascular neurosurgery, and of course also do open cerebrovascular surgery. By now, those of you who've been repeat visitors, you're probably sick and tired of these slides, but this is the last time I'm going to do it. So these are our two main centers, University of Miami Hospital and Jackson Memorial Hospital. It's been a lovely ride with wonderful speakers, and this is what we've gone through in the last 15 sessions or so. And this is it, the end of the line today. Those of you interested in pediatric neurosurgery, please tune in on Mondays with my colleagues from pediatric neurosurgery that are doing a similar thing. I thank my team here, Ingrid, Roberto, Cristina, and Ignacio, for putting up with me all these months since May 2020, when COVID kind of took off. Particularly Ignacio for doing a fantastic job running these webinars. If you want to watch what you've missed, it's all recorded. You can visit this website at the top, our YouTube channel, and watch many types of vascular and skull-based topics that we've covered in the last 30 sessions. Feel free to email me. I'm on Twitter. You can also join our departmental Instagram and Twitter feeds. Today, I am delighted to finish the series with the current panelist. Let me start by introducing Art Day. Art is a professor of neurosurgery. He is a vice chair of program director and director of clinical education, Memorial Hermann Misher Neuroscience Institute in Houston. Most importantly, Art is one of my mentors. Many moons ago, in '94, I was Art's fellow for 6 weeks when he was in Gainesville. And I cannot tell you that among the things that I learned tremendously from Art is particularly his 3D understanding of aneurysms, how to clip them, his true neuroanatomical approach to approaching clipping of aneurysms, among other things. But that is certainly something that has marked me the rest of my career. And it's a great pleasure to have him be kind of on the last session that I have put together. So thank you, Art, for joining. Chris Ogilvy, professor of neurosurgery at Harvard, director of endovascular and operative neurosurgery at Beth Israel Deaconess Brain Aneurysm Center. Chris and I have been friends for many years. We share a common mentor, Roberto Heros. Chris, a couple of years older than me. Chris, of course, besides being an accomplished open microvascular neurosurgeon, also has been doing endovascular for many years, truly a duly trained neurosurgeon who also has co-founded the Brain Aneurysm Foundation. So, Chris, I am also looking forward to your presentation. Howard Riina, professor of neurosurgery, neurology, and radiology. Howard is vice chair of the Department of Neurosurgery at NYU and director at NYU Center for Stroke and Again, Howard is a very close friend and duly trained neurosurgeon who will I'll be very interested to hear what Howard has chosen for his presentation. As you will see, the theme I've assigned the speakers today, I'll show it to you in a slide in a minute. But last and not least, Basant Misra, who actually will wake up in Mumbai in about an hour perhaps to join us. It'll be about 4:30 a.m. So that's why he's not with us from the beginning. Basant has been a friend for many years. He is head of the Department of Surgery in Mumbai. He is also very active and very prominent in the World Federation of Neurosurgery. He's first vice president of that organization currently and has many, many other titles, and he will join us later. What I have asked this august group of very experienced people is, I think, is a very interesting theme. I told them to give us the lessons that they have learned from the most impactful cerebrovascular cases in their careers. Because this, I think, this is one of the ways they could probably communicate to you, the younger audience, what is it that marked them, what they've learned in their extensive experience, so that they can hopefully shorten your learning curve, the younger audience, as you embark in a career in cerebrovascular and or skull-base surgery. So I'm gonna shut up right now, and I'm gonna invite Art to unmute his microphone and share his screen and start his presentation.
Can you see my screen?
Perfect.
Okay. Well, first of all, I'd like to thank Dr. Morcos for inviting me to speak today and to talk about a little bit about my journey to understand the role of embolization in the management of AVMs. And it has been a journey. Trying to change the slides. There we go. So I have, this is my disclosure slide. The medical school still requires us to do that, but none of them are relevant for our discussion today. AVMs are quite formidable lesions. I think all of us in the realm of cerebrovascular are full of stories that we can talk about. I mean, my first experiences, in fact, the first neurosurgical procedure that I witnessed as a undergraduate student, not even as a medical student, as an undergraduate student, was the resection of a brain AVM. And the management of AVMs, the surgery, embolization, radiosurgery, we all have our treatment paradigms that, at least when you've been doing this for several years, that we've sort of come to. And I think it's really important that we find a way, and I think that's why this lecture series is so important, to tease out the lessons that we learned that allowed us to arrive at these positions. With any surgical case or vascular case, since that's what we're talking about, in this case, AVMs, it's important to have a plan. Now, you can say going in, it's very important to have a plan and a strategy, but things change. They change right away. Clausewitz, the early 19th century German military strategist, basically said no battle plan survives the first contact with the enemy. And if you want a more modern interpretation of that, Mike Tyson, not known as necessarily the great military strategist or necessarily for being the most articulate, but summed it up the same way, which was that everyone has a plan until they get punched in the mouth. But when we plan to treat these lesions, it's important to have a strategy. My strategy was heavily influenced by learning endovascular neurosurgery. I was originally exposed as a medical student. I spent 6 months of research time outside of my clinical rotations with Alex Berenstein in New York, and that was in 1992. And just to put it in reference, at the time, the fellow with Dr. Berenstein was Kim Nelson, who's currently my partner. But Kim was Alex's fellow. I came as a student. And that was my first exposure to interventional. And the project that I worked on was reviewing the embolization of temporal lobe AVMs. And it was interesting because what we found was at the time, even with the more crude catheters, the limited types of glues that we had, was that that temporal lobe AVMs that had deep drainage had a very high rate of rupture following embolization. So this was back in '92. I basically came back to Alex to do a fellowship in '97 as a PGY5 during my research time, and did an enfolded fellowship. But at that time, the way we approached AVMs, at least in the Berenstein school, was to do multiple embolizations. And it was not unusual to do 6, 7, or even 8 embolization procedures on a single AVM. At the time, the glue that we had was NBCA. We used to get it from Canada. I don't even know the legality of how it was brought into the country, or even how it was sterilized, but that was the how we brought the agent in, and that's how we used it at the time. And the strategy was an aggressive embolization strategy. Patients were often symptomatic, but Berenstein had a very, very large, and still does, a very, very large referral practice for brain AVMs. And we would attack sometimes grade 4 and grade 5 lesions and try to whittle them down. Embolization was used as the standalone treatment, or it was either followed by surgery plus minus radiosurgery, not unlike the way we have now, but it was a very, very aggressive position. So a couple of cases stand out in my mind when I start thinking about the role of embolization. These cases that I'm going to show, try to illustrate the point with 2 cases primarily that occurred about 10 years ago. I'm calling the first one too hot, or not enough embolization. So essentially, a 41-year-old mother of 4 at the time, with a left occipital AVM presenting with a mild field cut and severe headaches. The field cut had been new, so there was probably some micro hemorrhage at the time. This is a left internal carotid artery injection. You see the AP and lateral, and you see a fairly formidable lesion, but not something that couldn't be addressed with the combination of embolization and surgery. The posterior circulation was interesting to me because at the time I felt that doing the embolization to the portion of the nidus, and this was a journey for me. So I'm trying to impart a little bit of how I arrived at the current strategy of embolization and the role of embolization. But at the time, I was looking to embolize portions of the AVM that I thought would be the most difficult to deal with at the time of surgery. And the most medial and deep portion of the lesion also contained what we would call, intranidal aneurysms, or features that were concerning. And so you can see on the 3-dimensional from the anterior, multiple intranidal abnormalities within the lesion, and particularly along the deep part. And I wasn't concerned at all, on the more superficial portions of the AVM nidus. The posterior injection seemed to give direct access to that portion of the nidus. So this sort of inferior medial portion of the nidus, which again on the 3D, you can see containing these intranidal aneurysms. And that was the part that I attacked with embolization, and actually had a fairly good result, I felt, with the embolization of this very small portion of the AVM nidus that I wanted to address. And then I took the patient to surgery. That's just a post-op image, but I took the patient to surgery. It's more important for the surgery. So at surgery, I encountered significant and continuous bleeding throughout the entire operation. I wish I had a video for it, but it was a 13-hour operation, which is, I would consider a very, very long operation for as compared to most of the procedures that I do. There was significant and serious blood loss. I would say somewhere between 10 and 12 units of blood were lost. And the thing about the blood loss, it was continuous from the start of the operation until I was able to get the last bit of the malformation out. And just to sort of impart how intense the operation was, at times when the blood loss was so great, the patient was having an arrhythmia, and the anesthesia said, the patient's having an arrhythmia. And I said, no, the patient's about to code because they need to be resuscitated more and you need to give more blood. And that's exactly what happened. They kept giving more blood and then the arrhythmias went away. And ultimately I had to give some adenosine to try to get around some of these, really all these little nidal features fell apart during this. And the lesson learned that I learned from this was that the goal of preoperative embolization here was not met. And obviously I was able to get the patient out of the operating room, and in one piece, she still had her field cut, which really never improved much in long term. But I get a Christmas card every year and a phone call on her birthday from her and her husband. But this was one procedure that really, really stuck with me and stayed in my mind. And the embolization didn't help one bit. And it stuck with me for a while, is that here I thought I had identified a component of the AVM nidus that I thought was going to be predictive of the difficulty that I might have with the surgery, and I was completely wrong. And that stayed with me for a while. If any of you recognize this, this is the exhaust of a Ferrari Formula One vehicle. That's from the showroom in Rome. But if you look at the exhaust, it makes me think of AVMs. Whenever I see these cars, they look like they're random tangles, but there's actually a science to designing the exhaust. But we'll continue here. So the second case that also sticks with me, whenever I think of the two most difficult cases that I've dealt with, this is the first one that I presented, and now the second one. This case is what I would call too cold, meaning there was too much embolization. The first one was too hot because the AVM was too hot when I took it to the OR. This one, there was too much embolization. So here, young gentleman, right cerebellar hemisphere AVM, had a couple of minor hemorrhages by the time he was referred in for management. You can see, again, some features that could be concerning, but certainly would be addressed with an aggressive embolization. And here you can see the embolization. So very, very large glue cast. Most of the AVM, you're not seeing any draining vein at this portion. And so this, if you're looking at the AVM, this is almost the complete opposite of the first case that I presented. And a lot of it had to do with, again, learning. This was a new embolic agent that we were using, and a new balloon catheter. So the onyx polymer was introduced, and people were becoming more and more comfortable with it. And then we had balloon catheters, and we were able to achieve good positions and push glue relatively deeply through an AVM nidus and really penetrate the AVM nidus. And so I'm sure you all know what I'm going to show next. The procedure is finished. He does well for a few hours overnight. Remember, he's going to the OR the next morning at 7 a.m. Of course, at 5 a.m., the AVM ruptures. So he's taken emergently to the operating room for removal of the hematoma and resection of the AVM, which is what you have to do. So an extensive embolization that almost looked like a complete embolization. There was some abnormality there, and obviously residual AVM nidus, but extensive embolization, including the venous drainage, precipitated a post-procedure rupture. And this gentleman had a very, very long recovery, extensive rehabilitation for greater than a year. But fortunately, the last time I saw him, he was back to this very fun-loving and wonderful human being. He walks with a bit of a limp, but you can imagine with a hemorrhage like he had in the brainstem compression that he had, that I was very, very fortunate that he woke up. So a lot of this, now, as I said, this has been a journey for me. I came from a very, very aggressive school of embolization prior to surgical resection. And like I said, the technology has caught up with sort of the philosophy of the management of the lesion. So the technology now of these small balloon catheters and the polymers have allowed us to really push glue deep into an AVM. If you've ever seen my good friend Saru Sheshrige show some of the AVMs, he likes to put multiple catheters in different parts of an AVM and fill different portions and close grade 5 AVMs. Now they still have a 20 to 30% post-procedure rupture, probably because you're not seeing some of the finer components of the AVM nidus, even on angiography. But what I was arriving at was basically this purpose of preoperative embolization. Certainly it's to reduce operative bleeding and facilitate the AVM resection. We still use the acrylic glues, but certainly Onyx has taken a major role now in the management. And these balloon catheters are quite good. We have catheters with detachable tips. I now, for resection, will not do more than 30, 50 to 50% embolization of a nidus, of an AVM that's going to go for surgery. I certainly always want to avoid venous compromise unless I was trying to go for a complete resection, embolization, but I don't even think, maybe with a grade 1 or even a grade 2, you might try to go for a complete embolization. But even those lesions, we're often recommending resecting those, even if we get what we think is a complete obliteration of a small lesion. And we still want to address these high risk features. Those are critical for all of our different treatment sort of algorithms. We certainly want to have improved visibility of the surrounding structures and minimize brain manipulation and the need for brain retractors at time of surgery. So EMBO has a particular role to make the surgery safer and easier and more smooth in its execution, I think. And this is sort of what I've arrived at. Certainly, as you know, I did my fellowship with Robert Spetzler, obviously one of my mentors, and the principles of AVM surgery that were sort of ingrained in me by Dr. Spetzler. There's always an anatomical foundation that we have to know or understand, the complete understanding of the vascular anatomy. Use all the tools that we have. We have now DTI imaging, obviously the 3D angio. DynaCT has become quite useful at our institution. And all these things can be done in the new biplane rooms. All this imaging can almost all be done at a single session, and obviously MR. And all these images can be fused for all the image guidance systems, the surgical theater and the brain lab. The operative technique of meticulous dissection, and obviously intraoperative vascular imaging with indocyanine green or regular formal angiography. There's the positioning, the approach, ventriculostomy or CSF drainage when needed, and a sequence of events that has to occur in the operating room, where to begin, where to come down on the lesion, following a superficial draining vein down to the nidus, and maintaining your position outside of the nidus and not within, and constantly adjusting and checking your position with all of this wonderful imaging guidance that we have. And certainly understanding the branching and feeding vessels as they present to the nidus and the lesion. As I mentioned, basic brain anatomy and function, knowledge of the vascular anatomy, but also knowledge of vascular collateral circulation in case you want to manipulate the collateral circulation to help do a more complete resection of the AVM. And then there's also the specific vessel tolerance, which vessels can tolerate temporary ischemia and for how long. Resection involves mobilization and detethering, removal of arachnoid adhesions, providing access, as I mentioned, points of entry. If unfortunately there is a hematoma, to use the hematoma and the hematoma cavity to your advantage. And again, using branching vessels and superficial draining veins, which prevent and limit exposure to help provide the best plane of access. All of these things worked quite well for me until this gentleman arrived in New York. So I arrived at NYU about 10 years ago. Obviously, I was in New York 20 years ago and in Philadelphia before that. But Doug Kanzioka arrived about a year after I did. And he had a tremendous influence on, again, me arriving at the current role of embolization that I practice. Doug had felt very, very strongly that embolization material impeded the ability of radiation to obliterate a lesion. And so again, if I go back to that idea that I had with when I was training with Dr. Bernstein, of these multiple embolizations to try to whittle the lesion down, or a big aggressive embolization of filling the AVM nidus with a embolic material, this got in the way of obliterating a lesion that wasn't necessarily going to go for surgery by radiation. And so we stopped. So this is from Dr. Kanzioka's paper that I just had up there, where obviously radiosurgery alone, you get better penetration and more of the radiation effect on the lesion, whereas SRS and EMBO, there's less morbidity because you're addressing some of these features that we don't like that potentially could bleed while we're waiting for the radiation to have its effect. And so we basically stopped embolizing the AVMs prior to radiosurgery. So a lesion that we have decided was going to have a combination therapy, we would embolize the high-risk components after the patient received a dose of radiation. So what I've arrived at now in my practice is embolization rarely as a standalone technique. Even in the grade 1 and grade 2s that you can have, quote unquote, a complete embolization, I still take those out. There's definitely preoperative embolization for lesions going for surgical resection in that 30 to 50% of the nidus. But we see a lot of patients that are sent now for radiosurgery. And so embolization of high-risk features that led to either a hemorrhagic presentation or symptoms, or we feel might be something that's going to continue to cause problems during the period of radiosurgery, we will embolize those features after the radiosurgery is performed. So radiosurgery is performed up front prior to embolization to increase the nidus exposure to radiation. And so I just want to end with this last picture. This is for the residents and the fellows. A couple of years ago, before we were dealing with all this COVID, we had a exhibit at the Museum of Modern Art in New York, and they brought in all of the musical equipment of a lot of the well-known artists. And so here you see three guitars. One is the guitar of Eric Clapton that you see the back of there. One is Eddie Van Halen's guitar. He's considered one of the great innovators in guitar technique, and Stevie Ray Vaughan's guitar. And if you look at these instruments, you can they have been beaten to hell. They have been practiced on for thousands of hours, and they have been played and played and played. Chuck Yeager passed away, as you know, a week ago, and he was asked why he was considered such a great pilot. And he said because he flew the most hours. He would fly all the time. And so there's a lesson in here for all of us, but in particular for the residents, the fellows, to keep learning, to keep practicing, and to keep doing what we're doing. You have to do it over and over and over again, and you have to extract what doesn't work from how you provide care. So thank you, Jacques. I hope I didn't take too much time. I'm happy to answer any questions. That's our group. Thank you.
Howard, thank you. Exactly what I had in mind. Thank you. You showed your thinking process through those tough lesions. By the way, the audience, they usually know. If you have any questions to our panelists, please type them in the Q&A box in your Zoom windows anytime throughout this session. Can I invite you, Howard, to talk about what do you see the role of, I thought, an emerging role for transvenous embolization that your European colleagues are so enamored of? What are your thoughts on this?
So we've only done it a couple of times just to get a feel. It really hasn't caught on with us. The bleed rates are fairly high. Jacques Murray, when I've spoken with him, still quotes a 20 to 30% post-embolization bleed from the transvenous route. I think we have to understand it a little more. I think it makes sense on a certain level, on a sort of a physiologic level, almost like the way we present when we go after a fistula. If you can close the arterial and venous components simultaneously, I think if you're able to cross over from the venous side into the arterial side, glue, and then go back, that is appealing to me on a certain level. But I think a lot more needs to be understood.
And Howard, you have a question from the audience, my good friend, Dr. Ali Malik, who's asking you, how long do you wait after SRS to embolize an AVM?
We do it the next day. So Doug puts the radiation on, we keep them in the hospital, and then I go after the features that we don't like.
Michael Morgan in Australia, he's now retired, but I mean, as you probably know, for the last several years, has not embolized any AVM, and he's been a proponent of saying probably the other extreme is that embolization does not help surgical outcomes. And there are several, I guess, in that camp. I mean, would you have a strong argument against them if that's what they feel comfortable?
No, I don't think I necessarily have a strong argument. I think you have to arrive at your own treatment paradigm. I think that if you have a good strategy to attack a lesion, and your team knows that strategy, and you've practiced it over many years, someone like Michael Morgan probably had very, very good success. Now, Michael also used to put his patients in barbiturate coma afterwards, I believe, for 20 to 48 hours afterwards. So those are things that I don't necessarily believe in. So there are other things that he did in his strategy that I don't know if I necessarily agree with, but his desire or his plan to take an AVM to the operating room without embolization, I could support his decision making. As far as my own understanding, I think that when AVM embolization is done appropriately and correctly, in a controlled manner, and not too little, not too much, but just right. The three little bears there that I was trying to present. I think that it can make the operations extremely smooth, even for large, lesions or deep-seated lesions. Embolization is quite a useful adjunct.
Can I invite Art and Chris to? I know, Chris, you probably are talking about AVM, but I think, Art, you're going to be talking about aneurysms. What's your experience with EMBO for AVMs? If you can unmute your microphone, bottom left, Art.
Thank you. Close the door. No, I think Howard and I have very similar philosophies here. And I love the fact that he talked about too little, too much. And we've all made errors in each direction. But I think we're honing more and more towards what that sweet spot is in a lot of these mid-grade AVMs. And in that setting, I believe it really is quite helpful for surgical resection. I think the strategy of the radiosurgery then embolization is very novel, and it's actually makes a lot of biological sense from a lot of standpoints. But I think we're in a lot of what he said. I can echo. It's interesting. I'm going to talk a little bit about AVMs, but that when you talk about impactful cases, many times vascular neurosurgeons, the AVMs come up more than many lesions because they are such a challenge still, I think.
Yeah. Art, do you want to unmute and give us your thoughts?
Yeah, I share what Howard had to say. On the other hand, I do not take a grade 1 or a grade 2 and embolize it just to make the operation go faster or whatever. I think in that situation, I think a really good, thoughtful anatomic analysis beforehand is better than taking the small but real risk of embolization when you're doing that. It does make the surgeon have to work harder, but there's no question that there is a risk to every embolization procedure. So I think we're talking about the mid-level, the difficult 2s or the 3s that we're talking about, where this is applicable. And in those circumstances, you want the same care applied to the sequence of the embolization that you would want the surgeon to take when he's taking it out. So it's not just start shooting stuff into the AVM, but get the dangerous part first, or the intranidal aneurysm part first, and then logically, anatomically go from there to a point where you feel like you're seeing the slowing down of some flow through the AVM that will make a difference in the operating room. So I wouldn't go nearly as extreme as Dr. Moore would do. I think Howard's hit a good balance point here.
Okay, Art, why don't I thank you, Howard, very much. If you could stop sharing your screen, and Art, let's have a go at sharing yours.
All right. Do I just share the screen? Is that right?
Yeah. Yes. That green icon at the bottom of the Zoom window. Yeah. And then.
Did I get it?
Yeah.
No.
Go to your PowerPoint. Go to your PowerPoint. We can see your screen.
Okay. PowerPoint is up.
Now we can see it. Yeah. Press that one. You went to the right one. Yeah. Press it.
All right. Let's see.
What? I think you're in a different screen, Doctor. You have double screens or something? You have two screens?
That's the problem.
You have dual monitors. What does he have to do? Here we go.
Okay, now go on top. And on the top left, it says display settings.
Keep going to the left, Art, with your mouse.
Yeah.
To the center, display settings. Press it. Press it one time and put duplicate slideshow. Yep, press it.
All right, everybody got it?
Perfect.
Yes.
We got it.
All right. Well, thank you very much, Jacques, for letting me to participate in this. It's a real honor and privilege to be on the panel with such distinguished people and good friends over the years. It takes a long time to become an experienced vascular neurosurgeon, and so people who can do it for a long time become friends because of the shared journey that we take. Mine has been a journey of surgical trip, not an endovascular trip. And I had the advantage of starting out with my training firmly based on anatomy because of my training with Dr. Roten and the ability to go at any time to the laboratory to look and see exactly where the shape of the vessel changes or what happens at this site and other spots. So I consider myself very fortunate. Now I'm going to talk to you about clipping techniques, and particularly the use of fenestrated clips in neurosurgery to make an operation that is easier. As we all know, that ruptured aneurysms or aneurysms can be treated by endovascular means, but there's no question that the harder ones are the ones we often have to tackle. And so being able to use a more sophisticated methodology for the clipping strategies involving fenestrated clips, I think, is something useful. So I want to use a case that I experienced to demonstrate how I've evolved where I am in this process. Now, just like the endovascular person, a neurosurgeon clipping an aneurysm has a working angle where the plane of the clip, as you can see where the clip blades you're sawing on the side view, should run parallel and reconstruct the flow parallel to the exiting two branches coming out of the aneurysm. And that works really well when the two branches go off to the side and the clip can pass down from the right branch to the left branch without having to go through or around the two branches themselves. If, on the other hand, the aneurysm looks like the man who just got arrested holding his hand straight up in the air, and you have to go around one arm to get to the neck and then get to the other because of the way the angle projects, the clipping of getting down that line between the two branches becomes more difficult. And that's where the potential for using fenestrated clips has a natural ability to go along the plane between one branch and the other, encircle one of the branches and go to the other. So in theory, there are then a number of aneurysms that can be reconstructed with fenestrated clips. The problem comes in with one of two things. When the aneurysm has developed thickening or calcification in its base, then it is very difficult to get anything across that calcification. And the second is when the aneurysm neck is between two very closely approximated arteries, like in the anterior communicating and the A2s coming out, where the space between the two is so small that it's very difficult to get a clip in between that will fit and secure the aneurysm. I'm going to use this case to describe how I have gravitated over the course of time to use this methodology. And of course, I also benefited from the maturation of new technology called, variable fenestrated clips. When I started this process, the only fenestrated clip was called a Drake clip, which was an instrument of major risk. The subtleties of that device were nowhere near what we could do nowadays with the modern fenestrations. So my case that stimulated my journey was this woman of 50 years old who began with a rapid visual loss over several months and came in with a dense bitemporal hemianopsia and almost blind in her left eye. And she has this giant superior apophyseal artery aneurysm. This was at a time when the term superior apophyseal artery aneurysm wasn't necessarily a common thing. This was just a big paraclinoid aneurysm to fix. But I did this operation, and I noticed that if you look at the CAT scan up at the top right, you can see the layer of the calcification in the neck of the aneurysm that is classic for this particular lesion, and yet I was unaware of how to deal with it or about its particular repeating cycle in these kinds of aneurysms. So I took the patient to surgery and used a paradigm that was evolving at the time with these new right angle fenestrated clips. And that was to open the clinoid up well and maybe open the dural ring to free up the artery a little bit and then separate the superior apophyseals and pass a right angle fenestrated clip along the parallel to the carotid artery, jam it up to the distal ring, and then you had the aneurysm clipped with a single a clip in the artery, lived happily ever after. That was the technology that I began and practiced for quite a while. The clip was parallel to the parent artery and looked good frequently. This woman, on the other hand, I stacked several longitudinal fenestrated clips along parallel to the artery. This was an intraoperative arteriogram, which at the time showed you couldn't see the lumen of the artery going through it because of the clip artifact. But the woman woke up slowly and was not speaking well, and she became progressively more confused. In fact, she was progressively going more aphasic. An early scan showed some edema that I could attribute to something that might have been technical in the exposure, but over time she developed a hemispheric ischemia and wiped out her whole hemisphere, became aphasic and hemiplegic, and obviously was a disaster in the coming. Why did this happen if I had such a good concept of how the clip should be applied and its direction? Did not take into account the secondary events that happen in the aneurysm when the clip is placed that are reproducible and predictable and can be managed very much better than my initial foray into the thought process. So I went through my database. I at the time was doing at least nearly 100 of these aneurysms in the paracellular region a year for a while. For 2 or 3 years, that was all I seemed like I was doing. And the process of looking and diagramming these and looking at their shapes and relationships led me to recognize that what I was encountering in the operating room with the superior apophyseal artery aneurysm as they grew was reproducible and manageable if I did it a little different. This is a schematic of what the superior apophyseal artery aneurysm looks like as it's in the internal carotid artery and the cavernous sinus. It goes forward and then spirals around medially and then goes around. The aneurysm then comes off the medial surface, but as the aneurysm grows, the shear force against that artery wall creates a thickening and then ultimately even a calcification of that medial wall of the artery right there at the base of the aneurysm where you're trying to put your fenestrated clip into the end. And that will either prevent your clip from closing completely or will push the clip blade in on the carotid artery, or potentially will cause compromise of the lumen of the vessel. So how do you deal with that? Well, I looked at a couple of my pictures. Here's a smaller aneurysm of a similar type, irregular multi-lobed superior apophyseal artery aneurysm. And this is what it looks like in the operating room. You can see the artery with a single fenestrated clip going down the point, but look at this atheroma that is exactly what I described there, right there at the proximal edge underneath. And if you put a clip into that area, you have getting an unpredictable response of how well the clip will close, and unpredictable response for what's going to happen to the parent lumen if it slides into it. Here's what the clip would look like, and you can see the clip going on at the bottom right film where the clip is being pushed into the lumen of the artery and potentially could lacerate it right there at the edge of the atheroma with the vessel. So I came up with a concept that perhaps if I angle the clip parallel to the atheroma instead of perpendicular to the artery, or parallel to the atheroma instead of parallel to the carotid, that could be managed. And so the paradigm of how to put these fenestrated clips on in the proximal portion of the carotid artery in this particular location was to stack them circumferentially. They didn't have to be long. They just had to be close enough in proximity to get past that atheroma. And then the distal part of the aneurysm could be managed in a very straightforward fashion without a complex fiddling or disturbing the atheroma whatsoever. Here's the end result of that aneurysm being clipped, and you can see the lumen well preserved and the patient well. So I thought for a while that this was the way to do it, and over the course of time, the incidence of visual loss and the incidence of any ischemic situations dramatically went down for this aneurysm, which I consider a very technically difficult aneurysm when they get larger. Clearly, nowadays, I would much prefer to pipeline them if I had a choice. But when you don't have a choice, perhaps for visual loss or whatever, this kind of construct was the one I arrived at as the way to treat these aneurysms more safely. It can even go to extremes where you stack them up to this degree, where you actually, this is my terminology for an external pipeline, where instead of putting the thing on the inside to make the vessel, you just put it on the outside so the artery can't grow any bigger than your fenestration. And you just stack them up, and you get a check every year from your clip provider for contributing so much to their economy.
It's still cheaper than the pipeline, Art.
It is, I think, very much so. Now, I then went to other aneurysm sites. This is a real ophthalmic artery aneurysm arising just beyond the ophthalmic artery origin. And my paradigm for treatment in that scenario was, again, a radical removal of the clinoid down to the optic strut, and then putting a side angle fenestration across the neck of the aneurysm parallel to the carotid artery. The thought processes, on the other hand, went astray on numerous occasions as these things got bigger, because just exactly like superior hypophyseal artery aneurysms, the artery, as it comes around and makes its bend, as the aneurysm gets bigger, you get a laminar effect of thickening and then calcification on the anterior wall of the ophthalmic artery. And then when you put a clip across the base parallel, it won't close. It's a real problem with getting the thing secure to get acute decompression of the visual system. Here's an example of a case just recently in a person with losing vision in her eye. She has this ophthalmic artery aneurysm, as you can see, and you can look at the warning sign of this study, and that here's the ophthalmic artery on the lateral view coming out, going forward to the eye, and there's a gap between the ophthalmic artery and the origin of the aneurysm neck. So you might say that might be not even an ophthalmic artery, it might be a dorsal variant or some sort of distal artery. But that is not the case. That is the thick atheroma in the anterior wall that's generated by the force. It's reproducible every single time on this particular aneurysm, and you can expect to see it in the operating room, and it will be a problem. So here's how I deal with that now. Here's a case that we just did. Here's the aneurysm now, and you can see it pulsating there. It looks like a skinny neck, and I usually start these off with a temporary clip just to get some working room parallel to the way I'm going to use it. And now I'm going to put a similar temporary clip, a gentle curved clip along there, but you can see neither one of these aneurysm clips close. There's a gap in between their blades right there, and it won't let you close. I'll put another one, it still won't close. So in the process, then this aneurysm is still pulsing. I don't have control of the pulsing, so I'm going to go distal to that spot, distal to the atheroma, make the artery a little bit narrower, just a working room, and then start a process of reconstructing the artery, the aneurysm neck around the atheroma. There was a time I used to use a clip applier, or some sort of clamp to do this, but this is much better. I'm going to take off the proximal clips because I've gotten the aneurysm somewhat smaller. I'm going to put a permanent clip up there proximally to parallel the curvature of the carotid artery. And then I'm going to handle the atheroma directly by using fenestrated clips to go around it. So getting the clip down to the base, even though it won't close completely, the aneurysm still pulsing. Now I'm going to fenestrate the atheroma. It's going to go around that fenestration from a little bit different angle. Here's the atheroma in the artery, going around it with a fenestration, just beyond it, and getting the terminal portion of the aneurysm taken care of. And now I can come on the proximal side of the artery here, the atheroma, and get the top of the vessel right here, and put the last little clip, and it will take care of the aneurysm without me having to do something to crush the atheroma. Then you can open up and you really can see how thick this atheroma is. This is it has to be cut away. See how thick that wall is. The whole wall was parallel, and it really becomes a difficult thing to deal with until you really get it open. You can see how very thick that particular wall, reproducible on every single ophthalmic aneurysm that gets bigger when you encounter this process. And here's the post-operative clipping result on that lady who went home in a couple of days doing very well. Now, the same logic applies to the giant middle cerebral artery. In the typical bifurcation of the middle cerebral artery, where the artery comes down to the genu and then makes a sharp bend backwards, the aneurysm continues as a projection, and the anterior inferior portion of that aneurysm will start to develop that thickening, just like the curves at the ophthalmic and at the superior apophyseal. And the atheroma then will be in the way of you putting the clip across that aneurysm. And of course, as it gets bigger, it becomes even more problematic about what to do. Here's the situation in the same sort of schematic where the artery comes in, there's a terminal portion of the M1 segment, and the atheroma develops on that inferior anterior wall, which will prevent you from doing something. If you can fenestrate that vessel and recreate it, and it becomes a standard sort of a clipping application once you see it applied. Here's an example of that case. A man presented with seizures and a subarachnoid hemorrhage, who has a partially thrombosed, multilobulated middle cerebral artery aneurysm. Here's the operative view, and we saw calcification on the previous film, on the CT scan. So I'm opening the Sylvian fissure, spreading the veins to let you see the fissure, and you can see the arteriosclerotic base of this aneurysm coming into play immediately, separating all the veins that were adherent to the vessel and doing everything I can to spare them. And then there are some adhesions of arterial branches until you come and see the aneurysm itself after I relieve these attachments. Now the aneurysm is being dissected. This is an M2 branch. I'm dissecting the M1. The carotid is coming around here. Here's the M1. I'm finding a place in the M1 segment, and there's an example of some of the atheroma in it. Finding a segment of the M1 segment where there are no lenticulostriates and putting a clip out of the way. There's the obstacle right there, that big atheroma in the way. It's going to run right down the long axis of that terminal vessel. So a fenestrated clip large enough to go around it and get to the other side. Usually I put one close and then put another one distal to that one, and I can take off the one that was so close after I decompress the aneurysm. So in doing that and letting it slide across the atheroma in the plane that I wanted, I don't have to change the plane of the theoretical best thing to do. And of course, I usually put 3 clips on and then take off one to give me working room to work on it. Now I'm adjusting as you see, the proximal clip going back where the second clip was, and you'll see the release of this artery from giving just a little bit of a room there. Now it just came free, and the middle cerebral M2 branch is now free of the atheroma, opening it up, all the necessary part to make sure you are completely done with these, and you'll see the atheroma again in a very predictable spot along the middle cerebral artery when they get to be this size. Opening them up, and then you can collapse the aneurysm physically if you need to, but you make sure that you're all right and have control and no back bleeding, and then taking off the temporary clip when the time comes. I'm adjusting this one a little bit because there was a little branch caught in the clip that now has been released. And then the temporary clip coming off with restoration of flow. Again, couldn't be done with the yellow Drake clips, but now you see the reconstitution of and the atheroma left behind in the vessel, but the rest of the neck is very well taken care of. And then going to the postoperative arteriogram, you see the aneurysm and you see the end result of the reconstruction, that atheromatous base left behind, but a clips running longitudinal to that base to open up and secure the vessel. So in final stage, I want to just talk about the ACOM region, because it is the anterior communicating artery aneurysm, a very common lesion with a superior projection, where fenestrations also are essential in knowing how to use. And in this case, it's not around atheroma, but it's around the fact that the two A2s are so closely applied that to get in there and clip that aneurysm in the ideal form requires you to go around the ipsilateral A2, then parallel to the ACOM, but not get the other A2 in your clip construction. If you have space, like on the case shown here, then you can use one of the standard fenestrated clips that go around one A1 or A2 and run along the ACOM, careful of hurting any branch that might be coming off of the ACOM when it's extensive. So you have room to work in there. But many times the aneurysm is very tiny in a small aneurysm, and these vessels are stuck together or very close together. Here's an example of a subarachnoid hemorrhage with this aneurysm at the ACOM, and the other A1 is right parallel to it, right in this area here. So there's the little aneurysm right in this particular region there. And how are you going to clip it? Here's that's the time for the fenestrated clip technology again, but for a different reason, because of space limitations. Here's the exposure. The right optic nerve. This is a right pterional craniotomy. And when I get into this area, I use two gentle retractors placed parallel to lift up the frontal lobe and no retraction on the temporal lobe. So in essence, I'm lifting up the frontal lobe away from the skull, but the temporal lobe is coming with it. So I'm not retracting or distracting. I'm mobilizing that frontal lobe up to give me a little bit of reason, of view. Here's the A1 segment coming in, and we're going to see the aneurysm now as I go along to expose the ipsilateral A1 and then do a gyrus rectus exposure to visualize the aneurysm well. Following that, freeing it up a site for a temporary clip was the first order of business. Not placing the temporary clip until I get near the aneurysm, and then the gyrus rectus exposure that gives me a little bit of a room to manipulate proximal to and distal to the aneurysm. The final portions of the gyrus rectus exposure, because it's a superior projecting aneurysm. And now going back into the subarachnoid space after I finish to now follow the A1 into the A2 area. So there's the contralateral gyrus rectus through the exposure through the gyrus rectus. So I know I've done enough. And then I'm going to go back to the A1 and follow it. So here's the contralateral A1 I just showed, and going up now to release the last of the adhesions to the midline. I find my ipsilateral A2. I find my first A1, the other A1, and then my A2, but I can't reach across because the aneurysm is right here, right in this region, right in here. And it's stuck between this A2 and this A2. It's right in there. So using, in this case, a provision of shortening the shortest fenestrated clip to get one that's only 1.5 millimeters in length, and then the aneurysm right there, reconstructing it, avoiding this. There's a small branch right here I have to avoid to get around it, and it's going to run parallel to the ACOM and secure that. You can see the ACOM now being visible, and then the aneurysm still there. It's running along. So I had several clips prepared. They really can't be much longer than 1 millimeter in size, but they go right across the ACOM, the A2, and I progressively stack fenestrated clips along the course of the A2 to eliminate the lesion. Now I can detach the last little bit, pop the aneurysm, and have more room by moving the other A2 around. I can use a standard longer clip and get the last portion of that to make sure I've secured the lesion. So these were cases that I've used, I've demonstrated based on not being able to use a conventional clip or clipping strategy to use the two prongs. Sometimes the fenestration is a much better way to reconstruct that ideally parallel to the branches view. You can see the end result there of the A2 filling, the opposite A2 and the ACOM, and all the branches with three stacked small fenestrated clips. So these are just some techniques that over time, as we open surgeons have to do more and more difficult aneurysms, which are the very small ones in very tight places that you may not be able to put one blade in the other right in the crotch as tight as you want. Fenestrated clips really have a great value in reconstructing these lesions, at least in my experience. Thanks very much for allowing me to come, Jacques.
Art, this is fantastic. The subtleties of surgery that is not easily taught these days. And of course, you've always been a great communicator about those things, and the skill you've achieved through various, so particularly your knowledge of anatomy. Those are golden nuggets here, what you said today. Let me see. I see one. I had a question for you, but let me see the audience. Okay, well, Dr. Turkmani says this is really an art act by a master neurosurgeon. Thank you, Dr. Day, for sharing your experiences. Yeah, I agree with that. Art, can I ask you to comment on the MCA clipping techniques in general? As you know, many of the textbooks have, they say, well, you have to clip it parallel to the branches. Do you prefer, I've found that many times I clip perpendicular to the branches because that's the way the axis of the neck is, and that's the way you bring back kind of the defect in the internal elastic lamina. Can you comment? I don't know if my question is clear.
Yes, I understand.
Yeah.
All right, so the problem obviously gets amplified the bigger the aneurysm and the wider the neck. Now, when you put a clip that goes perpendicular to the neck, what you're doing to the branches, you're bringing the top of the aneurysm together, or the two branches together, and if you don't have a curve that goes around the artery, it follows the front and the back of the aneurysm in that crotch, you may well leave a dog ear behind on one side or the other. So for small aneurysms, there's no question I do that. I still do. When you have a small neck, yes, that's fine. But the longer the neck, the more I put in actually a fenestrated clip across that base and just stack the fenestrations, just like I said, because I know it's going to, you stack them like that, it works great, and it's easy. Once the first one is on in the right location, then stacking them securely becomes much easier to do than the second one. So I still use perpendicular clips like for small PCOMs or for many of the others. But these are the devices that I was describing today for the more complicated ones that have atheroma that prevents you from doing it. If you have an atheroma in your middle cerebral neck and you put that perpendicular thing to it, it may slide over the atheroma and shear it across the neck, and then you've got a real problem. So that's why I try to stay away from it.
Okay, and Art, can you comment, as you know, we always have choices between the sizes of the fenestrations of a clip. When do you tend to use a small fenestration? When do you tend to use a larger fenestration?
In general, the larger fenestrations are for carotid artery lesions. When you have a big parent vessel, I try to match the hole with the parent vessel. So when I get out to DACAs, to distal anterior cerebrals, or to distal middle cerebrals, or I'm using the small fenestrations, and so sometimes though the atheroma is so large that you actually go all the way across the neck of the aneurysm to the opposite side to gather the neck from the other side, and then you start clipping the proximal side as you come towards you. So the big fenestration allows you to gather up a lot more space to reach that other side before you treat it. You're familiar with that, I'm sure.
Yeah. And I like sometimes, the other thing is the bigger fenestration allows you more room to see, to put the
Yeah,
next clip. That's the other thing. And my warning about fenestration, not warning, but people, I mean, but beginners need to understand that the junction between the fenestration and the blades is not a discrete point. The clip is made to curve there. So they've got to be careful that they actually are covering the piece of tissue they want to cover.
yeah,
It's a transitional, the fenestration transitions into a blade. It's not
yeah,
like a sharp, you know what I'm saying? That
yeah.
curve.
And it's got a tactile sensation as well as a visual sensation. You can feel it going over, and when you feel it sort of slide into a slot,
Right.
you're past the whatever. So you gotta, have a sensitive digits as well as the good eyesight.
Right. Chris, Howard, comments on Art's presentation?
Well, obviously, fantastic presentation, Art. It's always a pleasure, and you always learn something. I don't think I've drilled down a clip to make it a little bit smaller, and that's always a problem with the smallest fenestrated clips are usually a bit too long. But I agree, obviously, with everything that you said. I'm a big fan of the fenestrated clips, particularly for the superior hypophyseal artery aneurysms. I like the point that you made about the atheroma and the thickened portion of the wall, and using the fenestrations to secure that portion of the dome while you've secured the more distal dome. It was a delight to watch. Thank you.
Thank you.
Thanks. If there are no further comments or questions, I'll invite Chris to unmute his phone. Oh, Art, can you stop sharing your screen? I think if you go to the top where the red box is that says stop sharing and click on it, there you go.
All right, thank you.
And if you get called and I know you're on call, feel free.
I just had people in my office, so I'm trying to come back. But thank you very much.
Thanks, Art.
Slideshow.
Chris, all yours.
Good. Can you see my screen?
Yes, indeed.
Well, I really appreciate the real honor to be invited to do this. Pretty tough acts to follow that we've just heard. The last time I drilled one of those clips down, actually I got in trouble and had to explain why I was breaking policy of the hospital, modifying a pre-existing device. But actually, a lot of us have learned how to do those surgeries from Art. So that you just saw was really nice. And Howard, I think you're going to see some similar themes in what I'm talking about. I'd like to thank two of our fellows, one of our research fellows, Mir, and one of our residents, Aristotle, who helped me put some of these videos and some of this together. No disclosures, but in terms of impactful, when you sent us this title, it really made me think. And I'm going to talk about some impactful cases, both good and bad, but it made me think about impactful people. And it's interesting that the two surgeons you just heard speak, very experienced, incredible, rich talks, both talked about their mentors. And, it's something that never leaves you. And I met Roberto Hiros when I was a medical student. I knew I was going into neurosurgery. He solidified my thoughts to go into vascular neurosurgery. He's probably one of the driving forces. So I can't give a talk in Miami and not thank Roberto and acknowledge his really great leadership, mentorship, and wisdom. Equally like to thank Jacques for the invitation to do this, and Alan for the two of them carrying on the tradition set by Barth Green and Roberto in running the department, and really a department of great national prominence. My partners, Ajit Thomas and Justin Moore, who says Ajit Thomas, but it's really Justin Moore, are both endovascular and open surgical trained colleagues, and the three of us do the work here. And we have our nursing staff in the office in the endo suite, and our two fellows at the current time, who are endovascular and open surgical fellows at the same time. So when Jacques assigned the talk of impactful, it really got me thinking. And impactful really has two connotations. One is positive and one is very negative. And as some of the audience knows, one of my hobbies is stock car racing. And this was a Thursday night about 6 years ago when I was run into the wall during a race. And it's interesting because there's so many analogies between stock car racing and neurovascular surgery that you could give a talk just on that. But 4 laps earlier, life was good. I was running third in this race. And what happened was 4 laps later, this gentleman decided to run me into the wall going about 80. And you saw the result on the last slide. Interestingly, it was such a dirty maneuver that he was banned from the track forever for racing. And his son felt so badly, he sold me this truck. And the next week we were out there, we painted it black, we threw our numbers on it, and we were out there racing, which is another lesson in neurovascular surgery, that when you have one of these catastrophes, you got to get back on the horse. This is the car I've raced the last couple of seasons, and this is a different kind of impactful because with great practice and seat time, as which Howard was talking about, call it in racing seat time. You can call it seat time in microneurosurgery as well. You can win races and excel at this. It was interesting that Howard focused on AVMs and large AVMs, because these, I think, are some of the largest challenges that remained for us in neurovascular surgery. And when Jacques gave me this topic, I actually went back and dug out some 35mm slides from my residency. And this was a 22-year-old gentleman I operated on as a resident. It was after Roberto left MGH where I trained. And this gentleman presented with seizures, otherwise healthy, and I apologize, the images are really crummy, but they're made from 35mm slides from 28 years ago. And he had this large frontal AVM, as you see here. And this was his pre-op. We did some preoperative embolization, Howard. This was in the NBCA days. John Pyle-Spellman was our expert in this. And it was pretty piddly by today's standards. But it was the infancy, and everyone was learning and working together, trying to figure it out. After embolization, we went to surgery. I was a junior senior resident. I was a couple of months out of the lab. And this surgery went on for 28 hours. It started Friday morning. We finished at 1 o'clock Saturday. I see Howard smiling because I know he's been in surgeries like this. And back in those days, we stayed scrubbed the whole time. And at about 2 a.m., the surgeon turned to me and said, "Why don't you work on this for a while? I'm going to go lay down for a bit." And he left the operating room. And Roberto tells a story well of how when you go to a big AVM, at the end of the case, it's you, sometimes the fellow, and the scrub nurse. And that's what it was. It was me and a scrub nurse and the anesthesiologist. And in working this thing over the next 3 hours, I really just couldn't get enough of it. And despite being, you think dead tired, but it was really one of the most impactful cases of my residency. And the fellow ended up, and Howard, this is the days where the surgeon involved put the patient in barbed coma for 24 hours afterwards. But eventually he woke up, went back to South Boston and lived his life. Here's his post-op angio. You can see the cranie, old style burr hole and craniotome. But we resected this, and he ultimately did well. Well, just like I showed you that car that crashed, sometimes that happens in AVMs. This was a 40-year-old who had headaches. And again, these are images from 35mm slides a number of years ago. I was junior staff at the time and decided to take this on, which I should not have taken on. And she presented with left arm weakness. You can see this sizable AVM. This just gives you a little flavor of the angiography being fed from both ACA, MCA, and some components of the MCA, of the PCA. If you look carefully, you'll see wax drawings on the images, which is what we used to do because these were regular X-ray images. But I dug into this thing with an agreement with this woman that I would stage her surgery. You can see there's external feeders as well as internal feeders. And I was going to do this in 3 stages. And in fact, I did 2 stages of the surgery. Here's what the operation looked like. Again, these are very old images, but you can see we took off basically the top of her head here on the right side and half on the left side. And in doing this, got these blurry photographs of exposure of this thing and worked on it over 2 sessions, about 8 or 9 hours each session. And in fact, and just telling you the truth here, this is what we did. We laid a material in along our resection plane in between the resections. And you can see here the angiogram after the second resection where the front part of the AVM was gone, but the back part is all still there. And at that point, she had planned a further stage, but she woke up with her right arm plegic and her right leg paretic. She refused any further surgery. The leg recovered. Actually, she ambulated. The arm had partial recovery, but she had no useful hand function. And I followed this woman for 15 years. She continued to smoke cigarettes, and ironically died at 55. At 55, she got lung cancer and died from that, and not from her partially resected AVM. Well, a few months ago, this woman, 24-year-old, came in with acute onset of headache. She was neurologically intact. This is her CT scan, and you can see here a couple of things. First of all, you see the AVM on the CTA. You see bony erosion here, and everyone knows that that triggers you to be sensitive as to what's going on with the transosseous flow or what is causing that. Here's the lateral view of her CTA, coronals, and this is some of her angiogram. And that varix, that bony erosion was actually due to a varix, which you can see here, which was partially fed by external supply, partially by internal, but it was mostly external dural AVM, really. A component of this was a dural AVM, in addition to a large parenchymal AVM. Well, at 24 and a right frontal lobe lesion, we discussed the situation with the patient and her family. This is just showing you the external supply. And this is the right external. Both left and right externals fed it, and it was fed mostly by the right ACA, but as these things can do, it sucks the blood from the left to the right. So the right injection, although you can see it on the right injection, it doesn't really do justice to what the AVM really looks like, which is on the left side when you inject it, which is how we embolized it. You can see it fill much better. These vessels here are actually still the arteries in the AVM, not the vein, as you might think at first glance. So with discussions, we decided to go ahead and plan for embolization and resection. And also buried in Howard's talk, which he implied in almost every slide, is that when we attack an AVM now, we have a plan. The plan is not just to go try to do some embo. It's let's going to embolize it and resect it, or in some of Howard's cases, let's radiate it and embolize it. There's a plan ahead of time for hopefully complete obliteration of lesion one way or the other. So we began our embolization, and I did this in stages. This is after the first, second, third, fourth, and then we did a fifth stage where you can see increasing amounts, now onyx, not NBCA, in the lesion with slowing of flow through a good portion of it, but there's still a pretty good portion of the AVM there. We put about 35 cc's of onyx in this AVM, but it's obviously much larger if you do the calculation of volume. And then as a final stage, I embolized those external feeders to that to part of the dural AVM. But actually what I don't show here is part of it's fed from the ethmoidals that come up the falx to the lesion. And here's the negative image of the onyx at the end of the procedure. Here's a 3D view of what we're looking at. And this is just the onyx cast after the embolizations. And what I did is, and what I usually do after the last embolization, usually a couple of days later, we do the surgery. Here's our MRI after the onyx. You can see the onyx defect on the scans in our coronal, as well as the axial and sagittal views here. Here's a craniotomy, and what I did for this was a craniotomy within a craniotomy. And what we've taken to doing is using a matchstick cutting bit for our craniotomies. It seems to be a better cosmetic result, but with this, the dural transgressions are fewer. And what I did is, here's that varix, and here's that bony erosion. So I cut a small craniotomy here, and then the large craniotomy here for the AVM resection. And you can see on the screen on the right, we left this varix buried in the bone for the moment. And we had the dura exposed and began working on the rest of the AVM, which you can see here. Here's early in the operation before the dura is open. Here's later in the operation as the AVM is being excised after about 9 hours. Here's just a video of one of the resident that Aristotle, the resident, made. This is starting our resection posteriorly and working around. And as you can see, there's a fair amount of tissue here, but other parts of the AVM, particularly posteriorly, I wanted to stay right on the lesion. And you'll see the result of that. We got bleeding as we went along posteriorly. During one of the embolizations, a catheter got glued in the AVM and broke. So there was about 8 centimeters of catheter. And I'll show you how we take that out. Here's removing that bony piece. Now, at this point in the operation, we had taken a lot of the dural feeders to that varix, and the varix had turned blue. So I felt we could be more aggressive. And here we were able to get the bone off that varix. I think if we would have tried that with one big craniotomy, we might have run into trouble. In this image, the falx, the sagittal sinus that runs here from front up here in the upper part of the slide to back. And here we're working down towards the falx, and you can see coagulating here. And what you see here as we work and cut is the catheter I told you about. This was glued in the AVM. So there was a broken piece still in the artery, but this gave us a chance by cutting it. Now it was free, and we were able to pull it out of the artery. It was actually down well into the anterior cerebral and into the carotid, but you can see here, it's not healed in. It was put in a few weeks earlier. And so by cutting it and we were able to just extract it. I've actually done that with the catheter that was glued in the groin at one point. We wrote it up, pulling it all the way from the groin to the head. This is the posterior lateral aspect of the AVM. And I think I was, as you can see, partially in AVM here, but I wanted to stay right on the lesion. So I tolerated some bleeding in exchange for getting into normal tissue, because this was getting into the premotor area. And in fact, she did wake up with a supplementary motor area weakness of her hand for a couple of weeks. You can see these are pretty large bore suckers, and Howard, we were a little hot, I think, on this. That is, we didn't embolize as heavily as I would have liked to back here. Your discussion of that is perfect. But we went ahead, and you can see by the number of clips over time, I was able to get control of this and continue to work around the AVM once this was under control in a fashion where we could excise it. And as I say, this took a number of hours, 9 or 10 hours to get this thing out. But we were able to eventually lift it out and then come underneath frontally, reach under it, reach the falx, take all the feeders medially, and elevate it and excise it from the resection cavity. And of course, along the way, as you can see here, we hit a fair amount of onyx, which is always a happy sight, because those are feeders that coagulate nicely and you can cut. And now here we are peeling it off the falx and finishing the resection, elevating it from the resection cavity. And for some reason that stopped. But in the end, we had a nice resection cavity. And her post-op angio shows the large vessels filling still, as we all know, with the immediate post-op. This was done the night of surgery. And what I've taken to doing is an angio 3 or 4 months later, after these things have shrunken down a bit, just to see the normal vasculature and make sure that everything is as it should be. Here's the left ICA injection that cross-filled the AVM vigorously on the pre-op films. She woke up with her left hand weak after surgery. That resolved over 2 weeks. And I just saw her a week and a half ago, and she's intact neurologically now 6 weeks after this surgery. Let me shift gears in terms of impact on an aneurysm. This is a 55-year-old woman with headaches, and she had an incidental basilar tip aneurysm. And here you can see the lesion. Here you can see the MRA. It's a P1. It's more of a P1 lesion than a basilar tip, and you can see here's a CTA I think she had done. Here's our 3-dimensional angio showing that it's more of a P1 lesion than a basilar tip lesion. And we went ahead and stent coiled this. And you can see the tines of the stent here in the basilar and in the PCA. And you're probably all thinking, what is so impactful about that? And you're right. This took about 40 minutes to do this procedure. It's become very commonplace in everyone's practice. You get a beautiful picture afterwards with a Raymond Roy 1 obliteration of the lesion. But realize that stent-assisted coiling had not been invented when I was trained. And this is an incredibly impactful technology. And what happened was, this was a technique. Here's one. You can see it has a so-called white collar sign. We think that's actual endothelialization over the aneurysm and cure of the lesion in a stent-coiled aneurysm. This technique evolved over 18 or 20 years ago. But what it made was the ability to treat wider necked aneurysms that were not treated by coils alone. And durability has subsequently been demonstrated. So I say, was this impactful? And I say, heck yes. And as many of you know, I did my endovascular fellowship as a full professor. And I watched the evolution of endovascular therapies from coiling to improved coiling to then stent-assisted to balloon-assisted coiling. And as I thought about this talk, I realized that probably was one of the subconscious triggers for me to want to do endovascular work. At the same time, I was advising younger colleagues interested in neurovascular surgery to get endovascular training, but I actually provided them with no role model for someone who had done this or did this. So in 2008-9, I did a fellowship at Buffalo, thanks to my colleagues at MGH at the time, where I had extra long operating days on Thursday and Friday. My clinic day was 12 hours on Saturday, and then I'd get on the plane Sunday and go to Buffalo till Wednesday night, come back and operate Thursday. This is what the impact of this on my practice. This talk actually prompted me to go back and dig out all my numbers. And you can see that we have operated on a little over 4,000 open surgical operations, and now coiled a little over 1,000, or not coiled, endovascularly treated a little over 1,000 aneurysms. And you can see on the graph, the blue is surgically treated. So early on in my practice, the total number was surgically treated. And you can see after my fellowship, we began to treat lesions endovascularly. And you can see the total in green actually hasn't changed significantly over the years. But what has changed, obviously, as in many of our practices, is the percentage of patients that we're treating endovascularly here in the yellow, or open surgically in the blue. And now it's more endovascular than surgical. Consider this patient. Here's a 56-year-old woman with mass effect from a cavernous aneurysm, intracranial. She failed test occlusion with poor collateral circulation. So I decided to proceed with saphenous vein bypass to the middle cerebral artery from the external carotid artery. And then we did the carotid artery occlusion at the time of the bypass for Hunterian ligation and thrombus of the aneurysm. Here's the woman's preoperative image. As you see, it's a right intracavernous aneurysm, which was producing cranial neuropathy, which was progressive. She also had a right, which is hard to see from this view, but when you look underneath, a right middle cerebral artery aneurysm. And then this is her CTA here. This is her angiogram where she flunked her balloon test occlusion. You can see it's pretty much an isolated hemisphere. And this is hard to see, but this is our saphenous vein on the CTA postoperatively. And you can see there's a clip here because we clipped that middle cerebral artery aneurysm at the same time. Here's the bypass graft here going through the skull, coming down out of the skull, and coming down to the external carotid artery. So we bypassed the aneurysm, clipped the smaller aneurysm, and then clipped the internal carotid artery in the neck to produce thrombosis of the lesion. And this woman did well. She ultimately recovered in terms of her neurologic deficit, but realized this was done 9 years ago. Similar patient, 66-year-old with cranial neuropathy and a cavernous carotid aneurysm in 2013. The angiogram confirmed the lesion with no thrombus. She had left cranial neuropathy in this aneurysm. And Howard has been one of the instrumental people in bringing this technology to the forefront. And interestingly, pipeline and flow diversion, but the pipeline PUFS trial was just going on as I was a fellow in endovascular. So that's where I did my first pipeline cases, was during the PUFS trial. And of course, this is her angiogram 6 months after flow diversion, where the artery is beautifully reconstructed. And at this point, her deficit's gone. She also had a small anterior communicating artery aneurysm, you can see here, which filled from the left, filled from the right. And at the time, I actually elected to operate on that. So her sixth nerve palsy worsened over the first 6 weeks as the aneurysm thrombosed after the flow diverter was placed. This completely recovered over several months. We had complete obliteration of the aneurysm, and she went on after that for a successful clipping of her unruptured ACOM aneurysm. So flow diversion is impactful on the overall management of aneurysms. And these are aneurysms that used to be treated with bypass or complex reconstructions. Aneurysms in the carotid circulation, fusiform, or previous, and aneurysms that we didn't previously treat because the risks were too high, particularly depending on the age and medical comorbidities of patients. It's also impactful on the endovascular management of aneurysms. So aneurysms previously treated with stent or balloon assist or coiling were now treated with distal with flow, and as you've seen in the literature, other lesions, distal lesions, bifurcation lesions, are being treated with flow diversion. And when I went back and looked at my endovascular experience, you can see that initially it was all stent coil or coiling, but as time has gone on, flow diversion, I think, as in many people's practices, has taken a much larger percentage of treatment of endovascular treatment of aneurysms over time. Couple comments on dural AVMs, because these I think are fascinating lesions that we've learned a lot about in the last 30 years in terms of treating these, led by initially by our endovascular colleagues and now by so-called dual trained individuals who really, where we can really dissect out the anatomy of these and attack, which the key is attacking the venous side of this. Here's a 62-year-old woman with worsening left-sided tinnitus. This is a case from a few years ago, and you can see her CTA showed some increased vascularity here. It turns out it's not an artery, it's all vein. It's all vein. You can see her lateral CT scan shows increased vascularity. Here's her angiogram. This is a left carotid injection, internal. So the internal carotid artery is feeding something here, which then drained from the left side of the head to the right side of the head through the posterior fossa and out deep venous drainage, as you can see here. She was initially, this is a petrous apex dural AVM. And these are, I think, are very interesting lesions because they're fed by both internal carotid supply and external carotid supply. They're in the petrous bone. So the external carotid supply is often supply that risks cranial neuropathy if it's embolized. But this was this particular patient's lesion. You can see the lesion here in the skull base. This is the venous outflow from the lesion. It's fed by carotid here and also from extracranial circulation, as you can see here, from the MMA, cardiotympanic, and meningohypophyseal. And the drainage was really through the petrosal vein. So this is, she was initially seen at another institution. They did a little bit of endovascular embolization, but what they did was a nice 3D angio. It really shows you the lesion. Here's the carotid artery. There's feeders from the internal circulation, and there's feeders from the external circulation. I thought it was just a nice view of that. And it shows you the venous outflow here. This is where it enters the posterior fossa. So treating these lesions actually is quite straightforward. All you have to do is occlude the venous outflow. Now, some may elect to do that endovascularly by going all the way through the vein and backwards. I think our techniques for that have gotten better. I'm not as comfortable doing that. I'm much more comfortable doing a posterior fossa exposure. And this is an operation which literally takes 20 minutes under the microscope. And this is sped up a little bit for presentation, but here you can see the vein coming out of the wall of the posterior fossa. The retractors on the cerebellum. You can see the cranial nerve. Here we are coagulating just some of the surrounding structures. And this is the operation right here. We're occluding the vein. It's stagnating in the petrous apex inside in the dura. The vein is now occluded. We cut it, and the operation's over. As I say, once you get the retractor in, it's literally 20 minutes of surgery. And this is her postoperative angiogram, immediate. So you can still see there's feeders from the internal carotid artery, but they're not going anywhere. They're dead ending, which is what happens in all these dural AVMs. And this is her angio. A very similar case that I saw just recently is a 72-year-old. I'll tell you, it's the same lesion, and in the interest of time, I'll move through it. The interesting thing about him is he had memory deficits and cognitive deficits, but no motor or sensory deficits. And here on his MRI, we saw increased vascularity, very suspicious. On these images, you can see in the posterior fossa here, the drain. This turns out to be the draining vein, and highlighted here on the CTA. And these arrows show exactly where it's exiting from the petrous apex into the posterior fossa. Here's his angiogram, internal supply, same thing. And you can see here's the lateral phase. This is the point where it's filling. Now, in him, he had a good, this is the external supply, and he actually had a clean shot at the middle meningeal artery. So we thought that would be a reasonable approach to try to get rid of this endovascularly. So we actually did an session of embolization here from the middle meningeal, not through the ascending pharyngeal or anything which we felt was dangerous. We felt the middle meningeal would be safe here. And we got almost all the lesion. Here's the lateral, but there still was some flow through the vein. And as everyone knows, if there's still any flow, it's got to be obliterated. So again, posterior fossa surgery, same exact thing as I showed you on the last case with the cerebellum. The one vein, one of the larger veins had onyx in it. There was a smaller draining vein right next to it, which did not have onyx in it, and that's what was filling the venous system. So we went ahead and were able to coagulate that, again, even milking it, I think the surgery lasted 35 minutes, 40 minutes under the microscope. But the fellow enjoyed coagulating and taking the vein as it exited into the posterior fossa. And his post-op shows a clean resection. Interestingly, over a couple of weeks, he improved, and he's now about 8 weeks out. And in discussion with the family on a phone visit, which a lot of us are making, they report he's continuing to improve in terms of his cognitive function. Here's a fellow, he had stopped driving. He had really been pretty much housebound, and they say now he's way more interactive and really kind of coming back to his old self, as they say. Jacques, I'm going to stop here in respect of Dr. Misra. I have one more case, but I'm going to stop here and thank everyone for their attention, because I really want to hear his talk.
Great. Thank you so much, Chris, for that selection of vascular cases and your extensive experience. One question from the audience, Dr. Zachary Barnar is asking you, how long do you wait between embolizations? I assume he's asking about AVMs.
Yes, and Howard, I'd love your thoughts on this. I actually, for this girl, the woman I did this summer, we waited about weeks. We waited a couple of weeks, 2 to 3 weeks between sessions. And then after the final session, resection within a couple of days. I think there's different philosophies about that. I'd love to hear others.
Yeah, so I'm not usually doing multiple stages anymore. Like I said, I try to do my embo. I bring the patient in, I do the embo, and take them to the OR the next day. I know some people like to wait 24 hours, and in your case, a little bit longer. I don't, in my practice, I haven't necessarily seen an advantage to that, waiting much longer, but I can't see a reason why you
Howard,
couldn't wait longer.
I could not agree with you more.
Yeah.
And that was it's a combination. This was a young woman, a lot of psychology at play here. We really had to lead her through this treatment step by step. But what you put in your talk and what you realize that when you do both the embolization and the surgery, you can control how much embo you do and when to stop, because you know what you can do at surgery. And it makes it, at least for me, a lot more straightforward when you're doing the embolization. And I think you showed that in your cases by getting that sweet spot.
Bassant, welcome. We are very appreciative you're waking up so early to be the last speaker of my series of 30 sessions since April. This is it. You are the end of the line, and we save the best for last. I introduced you earlier when you were not here, so I'm not gonna repeat the introduction. Bassant, please go ahead, share your screen and give us your wisdom, and we'll engage Chris and Howard later based on what your talk is.
Good evening, Jack. Good evening, friends. It's a pleasure and privilege to be here, and always it is beautiful with Jack all the time. We have been friends for decades, so let me see if I can share my screen.
We can see it. It just needs to be in presentation mode. We see it in navigation.
I'm trying to get that. Yeah, right.
There you go.
You seeing?
Yeah.
You seeing
By
it now?
now we're all experts at Zoom, Bassant. How many
I know.
goddamn Zoom things we've done?
Yeah. Okay. Thank you very much. I'm sorry I missed some of the talks. I saw the last part of the Chris talk, but it would have been a pleasure. But I was operating whole day, yesterday, so it's difficult, and I got a full day today.
I'm sorry.
So no, it's okay. It's a pleasure, as I said. It's a privilege to be honored to be here. So I'm very happy to be included in this. I think I have got the. Let me see. No, I got the wrong one. Sorry, just 1 second.
That one looked good.
And I will say that was another presentation of giant aneurysms. Just 1 second, please. You seeing now again?
Yes.
Okay, so this is for Jack's meeting. That was for some other webinar. So many webinars happening now. Okay, so I'll share with you some of my thoughts over the period of years and how things have changed in my practice. Slightly different than the last two talks. I understand that because I'm a pure microsurgeon. I'm not a hybrid surgeon. I have no training at all in endovascular. So it's a little bit probably biased because of that. But as it may be, let me share my thoughts. So that's Jack, always teaching. He's been many times helping with our meetings. And that's the last one. I promise you, showing me some videos of operations, nothing else. Thank you, Jack, for getting me here. Very distinguished gathering faculty here. So I'll go through some of these things which I think has impacted my practice and help the patients for the better. Now, this is something which, again, I have learned of so many things I have learned from Dr. Spetzler, a supracerebellar infratentorial approach for a thalamic cavernoma. This was done this week, so I thought it may be a good idea to put it here. This is a young man who had initially presented in 2017 with one bleed from which he recovered completely. And now he presented again with hemisensory anesthesia on the right side. This is the left side. And so that was the left posterior thalamus. There was the lesion there. So we did the tractography, which we thought that the tracts are all displaced anteriorly, and as you can see there, I'm sorry. And superiorly. So we thought the best approach would be if you can go from behind, the less likely that we would injure the patient and increase the deficit. So this is a semi-sitting position. This is the lesion was in the left side. So we having a trajectory from the right side, we had to take a small the tributary, which is which we could not manage to save because the space was very limited, but we left one large vein on the left side and then very thick arachnoid, which we cut. The major problem which I found in this is the distance one has to travel. And this gentleman was a tall fellow, and all the instruments were the limit. The reaching there was the limit. So we were using actually the transsphenoidal instruments most of the time to take out this lesion. But that was the only limiting factor, and the challenge was getting the instruments to there. Otherwise, there is no retraction at all, and you don't almost traverse any neural tissue other than the just very thin layer of thalamus, which is on the surface of the cavernoma. And that, of course, the entry to the thalamus was helped by the neuronavigation, which we used along with this operation. And you can see we are operating between some of these veins and the arteries. The vein of Galen is there. You could see the basal vein of Rosenthal. And we could completely excise, and that's the opened lateral ventricle there. And once we thought we have removed everything, we put an endoscope to see the anatomy better. That is inside the third ventricle. That's the roof of the third ventricle with the choroid plexus there. And just for the teaching of our resident, that's the foramen Monro. So we tried to do that. And then we put the endoscope inside the cavernoma cavity, and what we thought we have removed, there was some residual cavernomas was there. There was alive still, so we went back under the microscope. That was only for visualization, and then we took out the rest of that. And we could achieve a total excision without any increase in his deficit. He, of course, had this hemisensory hyposthesia, which persists, As I said, this was done Monday this week, still in the hospital. And this is preserved vein at the end of the surgery. And this is the post-op MRI the next day. So I think this choosing the right approach is key to the success. And this is one of these examples of such a thing, what we can do today. Now, I think one of the most impact in the practice of neurosurgery, let me say, is the advent of gamma knife. Whether you like it or not, I like operating microsurgery all the time, but this is something which I cannot achieve. A diencephalic AVM which had bled, and the patient, the AVM disappearing within 2 years, without incision, without a cut, without an anesthesia, without anything at all, any damage to the patient. I think this is a revolution. I would put this revolution in neurosurgery, probably one of the highest revolution, whether you like it or not. Appropriate selection of cases for gamma knife is probably one of the best things that has happened in neurosurgery. Gamma knife has got a lot of flack because many neurosurgeons unfortunately have used it for the wrong indications, causing damage to the patient, but for the right indication. This is one. And for example, in metastasis, something like that. I mean, this is unbelievably multiple metastasis, lifespan, the quality of life after that, unbelievable change in the patient's life. So this development, this impact to neurosurgery, I would put right up there of all the things that have happened in neurosurgery in my 40 years of neurosurgery career. So choosing the right modality, again, is the key to success. And in this case, gamma knife is the better mode of treatment than any form of treatment for this AVM, to my mind. Now about this one, this is one of my most dramatic cases. Jack might have seen it in some of the meetings. I have shown it many times. Now this is a 2.5-year-old child. About 11 years ago, 2009, the child presented to me an altered sensorium with heavily thrombosed, calcified basilar top aneurysm. You can see that this is the circulating component, and these are large thrombosed and calcified component there with gross hydrocephalus. So we put a shunt, the child became asymptomatic. In the next 48 hours, child was almost normal from unconsciousness, and then we really didn't know what to do. This was 2009. We didn't have very much other than coils, and we are very efficient endovascular colleague who did coiling, and 17 coils there. A very nice picture showing that the aneurysm is gone. Unfortunately, in the next 48 hours, the child deteriorated very rapidly to become comatose again and started extending. We did the scan, the hydrocephalus, the shunt was functioning, hydrocephalus not come back. So we were really in a dilemma. The father is a pharmacist, so he had some knowledge about science. So we had no choice to go in with a lot of reluctance. Do an extensive skull-based surgery, which I also, that's one of area of my specialization. So we did a OC, extradural anterior clinodectomy, intradural posterior clinodectomy, dorsum was drilled, and then we did a partial thrombectomy and partial removal of the coils, and then clipped the aneurysm. So that was the standard extradural anterior clinodectomy. And then we did a wide opening of the sylvian fissure so that to avoid undue retraction. And then that's the carotid artery there, and that's the drilling of the posterior clinoid, intradural drilling of the posterior clinoid there to give that some few millimeter of extra space. We have found this a very useful technique, especially in the posterior circulation basilar top aneurysms. And that does help us to reduce the traction in this kind of patients. And then we put, with these are the coils, some of it's coming out from the aneurysm as we always see. That's the basilar trunk, that's the right PCA there. And we're defining the neck of the aneurysm, of course, is a very wide necked aneurysm. So see, as I said, it's very well coiled. So we open up without a temporary clip first. And we decompressed partially, and then as you can see, we're decompressing some of the clot, and we cut it because there was calcium there, as I said. And then once we have done that, we define the contralateral PCA and SCA, and then I'll skip and go fast so that we save some time for some other cases. And then that's the defining the contralateral PCA there to get some space. I have decompressed the neck. So we put first one clip, partially occluding the top of the basilar, and then a second clip, and then a third clip, and the first clip is taken out so that the basilar trunk is, the top of the basilar is free and it's not occluded. And the first clip is removed. And so that's the end of the surgery. You see the brain is nice and lax. That is the second clip, and there was a proximal, this temporary clip was on the other PCA, which we removed now. And that's the end of the surgery. You see the brain was quite nice and lax. The patient had a very stormy post-operative course, 6 weeks in the ICU. This was a post-op period, when ventilation, and then in tracheostomy for 6 weeks. And this was 1 year follow-up. This is 5-year child was going to school. This was, as I said, 2009. So 5 years down the line, he came for a follow-up. He had a little deficit there, and mostly some motility problem of the eye movements. Other than that, he was fully functional. No swallowing problem, no role kind of deficit as going to school, as I said. And this was 11 years down the line. This year, during pandemic, he came back because he was said he was almost normal going to school, except he had a recent onset of double vision. We tried to evaluate it. As you can see, there is some motility problem, which was always there. But why did he develop? Our ophthalmologists, they evaluated very extensively, but we couldn't find a cause that of ophthalmology cause. So there was probably some kind of neurologic cause we could not, and he continues to have that little bit of diplopia, which is regressing on its own. And this is 11-year post-op because the aneurysm remains occluded, and you can see the circulation and the PCAs are occluded here. But this is fortunately very good, the fetal PCOM and PCA, so he is not compromised. And because this is a child, I think we got away with it, and taking up that case was worth its while. This is the MRI, the brainstem is intact. So I think this is one of my most dramatic cases of my life. So lessons learned that time, 2009, this was operated. Coiling is not a good option, as we know, for giant aneurysms today. Now, a few months after that boy, this gentleman came with this almost similar aneurysm, a little smaller than that, and exactly the same procedure, this partially thrombused, giant thrombused, partially thrombused basilar top aneurysm. Again, exactly the same approach, almost looks like a duplication of the approach, but the aneurysm was different. And it was surprisingly easy because the neck was free of any thrombus. So we didn't have to even open it. And we didn't have to put any temporary clips on the PCA or the basilar top. We just put two large titanium curved Yasser-Gill clips. And that's the right PCA. That's ICG showing this is the branch of right PCA. That's contralateral PCA. There's a very short edited clip. And this is the patient immediate post-operative CT angio and check DSA. We're showing complete occlusion of the aneurysm, very good normal vessels. The patient developed partial third nerve paresis for about 3 to 4 weeks. He came back after 3 months without any deficit, no deficit whatsoever. And he's actually, cricket is a game which is very popular in India, which is played in one of the states in India now. And this is again way back, just as I said, in 2009, same year as the other child I saw. So I think this is going to be a useful technique in spite of all the advances we have in endovascular arm. We sometimes we need this. Now, I have also a good practice of bypasses, and this is one of those cases, again, about, I think 15 years back. There's a lady with this cavernous aneurysm symptomatic, which we treated by high flow radial artery bypass graft. And after the bypass, we took down the patient to the angio suite, and we did an angiogram. You can see the bypass good. The ICA is still feeling, the bypass is still feeling in spite of not occluding the ICA, which would suggest that it's a good bypass. it is competing with the normal ICA and still filling. So we are happy about it. The patient was all right. So we occluded the ICA by coils in the angio suite. By our endovascular colleagues did that. Unfortunately, 3 days down the line, she started deteriorating. And then we took her back again, and that is what you see, that the graft is closed completely. The collaterals were reasonable, so our endovascular colleague was very reluctant to do anything because of fresh bypass. So we hoped that we will get away with it. We did not. The patient deteriorated, had an infarct, and we had to go on and do a decompressive craniectomy. The patient survived with hemiparesis, but that was very, very stressful and damaging for the patient. But what was interesting was during the operation, we saw that the graft was still pulsating. So the graft had actually gone into spasm, not block, not thrombus, which is very, very unusual. I talked to many cardiac surgeons. I have talked to friends, colleagues who are here can tell us their experience. Have they ever seen a graft which is occluded on angiogram, radial artery graft, which opens up afterwards? I haven't found that example in the literature, nor any neurosurgeons whom I have talked to have that experience. And none of the cardiac surgeons, my colleague, they say once the radial artery graft is gone, it's gone for good. But this was not the case. This was the graft post-op. After the decompressive craniectomy, we did a CT angio. You see the graft was completely patent. So this was a spasm rather than the block. So this is one of the lessons I learned that time. Probably we should have got to be more aggressive and try to open that graft, which we did not do. So this has problem in spite of I'm doing bypass since 1994. This does happen. So one has to be aware of that. And so after that came the flow diverter. So the flow diverter obviously became a safer and better option for proximal carotid aneurysm in my practice also. So many of these patients which I showed now go for flow diverters, especially cavernous carotid aneurysm, as we saw Chris showing nice example there. I'm sure Howard must have shown so many examples there. But it does not take care of all the aneurysms. Now, this is a gentleman who had a road traffic accident and presented after 1 month of the accident with recurrent profuse epistaxis, blind right eye, left hemiparesis, and on the CT angio, and we did multiple other DSA. He already had a MRI outside. Now, there is a pseudoaneurysm which was bulging into the sphenoid sinus. So again, because this was a pseudoaneurysm patient already post-traumatic, he had hemiparesis, blind right eye. My endovascular colleagues were the first, I referred to them, and they evaluated, and then they sent back the patient because they said we can't put a flow diverter because there is a fragment of fractured bone in the wall of the aneurysm and sitting inside, part of it is sitting inside. So we can't put a flow diverter. That's what they said. And they did multiple 3Ds, CT, and so on. So this is where we went in and did a standard high flow bypass and sacrificed the aneurysm, sacrificed the carotid artery ICA ligated in the neck, and also intracranially. Sometimes the routine cavernous carotid and giant aneurysm symptomatic when we do bypass, I just ligate the carotid in the neck. But it's important in a pseudoaneurysm that you need to trap it, as we all know, because the pseudoaneurysm is really can just blow out from the bypass. So it is always a good practice to trap rather than just to ligate. That's what we did it. And the patient, of course, the blindness did not improve, but otherwise the bleeding stopped and his hemiparesis is improving. So this was again something which we can do, which flow diverter did not achieve in this particular patient. Now this is again another very dramatic patient. This is a young man who presented to another unit with a acute subdural hematoma in coma. He had a decompressive craniectomy, survived, and was referred to us for a definitive management. Now, this is the blowout of the ICA. The whole ICA was diseased, which has ruptured and produced the subdural hematoma and produced the coma to the patient. By the time he came to us, he was asymptomatic. He also had a basilar top aneurysm, which are unruptured. So we advised that we have to do surgery, we have to occlude this, and we have to do a bypass. He ran away, which is not unusual in my country, to come back after a year with progressive hemiparesis and severe headaches. And then we went on to do a bypass. Again, a high flow radial artery bypass graft, but we have to excise, decompress, because this was 8 centimeter aneurysm, and the graft was not enough length was there. So we had to open it up, decompressed, and then the bypass. And then we send the patient for our endovascular colleagues to take care of the basilar top, again, which failed that time because they could not separate the posterior cerebral artery. So we went in and operated. As I said, he already had one go for the right side for the bypass. So there was some, and he had already decompression outside. So there was some, the gliosis of the brain, and the brain was there was space there. We did exactly again the same thing, drilling of the posterior clinoid, and we clipped multi-clipping technique of the, and that's the aneurysm there. There's a basilar top, the right PCA. You see the PCOM ending in it, PCA coming out there. There's a very globular aneurysm with the PCA incorporated in the aneurysm. There's contralateral posterior cerebral and superior cerebellar with the third nerve there. You can see it. So we put a temporary clip on top of the basilar, and again multiple clipping technique, and finally, something which Dr. Batchet has talked about it, the first a fenestrated clip, the blade taking the part away from the surgeon. I'm approaching from the right side, and then more clips. But finally, we could occlude the aneurysm, but we had to take the PCOM because the aneurysm otherwise was not getting killed. And finally, we could achieve a complete occlusion, and this is how it looked after 2 stages. The second was done after 3 months of the first bypass, and then the aneurysm, both aneurysm taken care of. This is again some about 8-9 years now, with the aneurysm remains occluded and patient remains intact without any problem. That's before the discharge from the hospital. Now, this is again something which I don't know whether the endovascular colleagues can do very much about it. Now, this is a guy in his 50s who presented with progressive visual compromise, more on the right side, and all his vessels were diseased, oligocephalic vessels, right side, left ICA, left carotid circulation, posterior circulation, all diseased. We actually were not sure how to manage this patient, so we sat on this patient for a period of time till about a year down the line. He forced us to do something, and the right side vision was getting compromised severely. He was losing the vision, and the right carotid aneurysm was actually the mass which was compressing the visual pathway. So what we did is the simple treatment of a bypass, high flow bypass, and just ligated the carotid in the neck. And we bought him some time. I know he's going to have problems because all his vessels are diseased. But this is again something which probably today, I'm not sure, but I think probably this would be the better treatment what we did rather than doing an endovascular option for him. Now, again, something which the endovascular probably cannot address is this 70-year-plus lady who presented with an infarct. And our neurologist evaluated and found a very distal MCA aneurysm. I am not going to present the video here, but you can see that the aneurysm with a thrombosed aneurysm post a very distal MCA, which opened up and inside to, kind of opening and closing the artery, making it patent in the left side, distal MCA. And again, this is something which needs to be addressed microsurgically. A very large, this is again a 60-year-old gentleman who had a 2-centimeter plus aneurysm, but very small circulating component, large thrombus component, presented with infarct to our neurologist. Angiogram showed an aneurysm, small circulating component. This is microscopic at the time of opening. This is left MCA bifurcation, huge aneurysm, heavily thrombosed, calcified. Again, something which need to be addressed microsurgically, which we did. Of course, the patient had infarct. We didn't improve that, but we saved him from another catastrophe. So these things led us to believe that some of these patients are still today, in spite of all the advances, are managed by microsurgery. Now let's see if there is very, very safe. We all know that this is safer most of the time from microsurgery, the flow diverters, but they give you some examples which are probably underreported. Now this is an unruptured ophthalmic large aneurysm, an ideal case for a flow diverter, which was done by another endovascular colleague in the city and well taken care of. The patient remained all right for about 6 weeks or so, and we started developing visual compromise, getting worse. And then he had one side, the left side, visual compromise initially a little bit, and he started having blindness, both eyes, which became progressed to almost functionally blind. which very rarely now are getting reported. And this is another case. ACOM, similarly treated coil and a flow diverter, again, getting worse on the vision over a period of weeks. This is a blood aneurysm. I think this was better treated by microsurgery. Now, this is a large and, excuse me, giant ophthalmic aneurysm, again treated in another very advanced endovascular unit, where the flow diverter 1, 2nd, 3rd, and this is the finally see the patient came to me when he was hemiplegic, blind both eyes. After 3 attempts at occlusion of the aneurysm, aneurysm still remained patent, and the patient, as I said, right hemiplegia, and he was almost blind both eyes. So these are some of the things which are unfortunately not getting reported as much as it should, to let us know there are also risks in the endovascular arm, as also there are risks in the microsurgical arm. So lesson learned, flow diverter is actually, these last 3 cases in last 1 year, all these patients are treated outside and been referred to me after these complications. Flow diverter is, so we realize that is not without risk and not a panacea. So when an aneurysm comes like this to me, like a 4 centimeter aneurysm with a mass effect, unruptured, visual compromise, this is a lady in her 40s who presented with visual compromise, circulating 4 centimeter aneurysm. What we do is a protective STMC bypass first, and then aneurysm or RAFI with multiple clips. As done this one, there is some redundancy at the base, which we accept rather than occlude the aneurysm. And the patient did very well. His vision, her vision improved, and she remains, the aneurysm remains occluded. What about aneurysm like this? This is a lady with bilateral MCI aneurysm. The right one has ruptured. The patient presented to us in coma with a large mass effect, large clot there, and subarachnoid hemorrhage. We operated in an emergency. And this is old technique of clipping and multiple clipping technique, and the patient improved over a period of time. And then we called her back after 6 months for the right MCI aneurysm. So both sides treated at an interval of 6 months. The right hand had bled, which was treated in emergency, and the patient remains left hemiparetic, but otherwise functional. Again, this is something I think better managed to even today, in spite of all the advances by microsurgery. Again, clipping, the oldest technique of clipping, and this is a disappearing art, both because endovascular things are improving, and also many young neurosurgeons are very expert bypass surgeons. So they would multiple bypasses here and many types of bypass now. But this is something which we could still do it by clipping. And this clipping, I think, is an art. We have to develop it. You can preserve all the vessels by multiple, and this stays, the aneurysm stays, blocked stays, doesn't fill up over it. We have 20-year follow-up of these patients, and the aneurysm does not fill up even after so many years. And this is another example of a globular aneurysm. Many of these MCA large aneurysms were globular, and the neck is very rounded, vessels coming out of it can be reformed by the standard clipping technique. And this is another such example where the clipping, innovative technique of clipping will helpful. This is endovascular treatment failed, and they didn't want to put this is a patient with subarachnoid hemorrhage, acute patient. They did not want to put a flow diverter, enterochoroidal PCOM coming out from the aneurysm. They gain wide opening sylvian fissure for the young neurosurgeon, a very wide opening so that you get space there. Then multiple clipping techniques, temporary trapping of the vessel segment. I will go fast forward, and then we open up the anterocline or the intradural. Basically, what I wanted to show is this multiple fenestrated clips, but unlike the blades remaining parallel to the parent artery, which is the standard practice we do, the blades are perpendicular to the parent artery, with an idea that the vessels which are coming out from the aneurysm remain patent, like the PCOM and the enterochoroidal. So that is a technique which we less commonly use, and this we opened the aneurysm. There was some bleeding in spite of the temporary clips, and then more clips and more fenestrated clips, and then we take off the temporary clip, We see the anterochoroidal, we do the ICG, and then more clips because there's some more redundancy. And then we do the ICG and also do the fluorescein. The fluorescein angiograph in our practice, we are very happy with it to see the very small vessels are better seen in my practice. We think it is in fluorescein rather than ICG. So this is a fluorescein angiograph with the perforators are better seen with this. Once we are happy with it, we take out. And what I just wanted to show is the post of, and we put most of these cases, we put thin slivers of cotton, again, something which I've learned from Dr. Spetzler. Now you see the clip blades are perpendicular to the parent vessel, and the vessel, the anterochoroidal PCOM and anterochoroidal coming out from those, so they don't get compromised. So that we call the vertical stacking, which is less commonly used practice, but the old-fashioned clipping can occlude most aneurysm. We still believe in that. Now, this is, of course, something which this was done about more than 10 years back. I haven't done a hypothermic cardiac arrest. This is a child from Bangladesh who had presented with a basilar top aneurysm with hemorrhage, altered sensorium. CT angio was not giving the right information. 3D DSA, you can see all the 4 vessels coming out of the aneurysm. So we thought this is the only way we can do it. We say hypothermic cardiac arrest, which we did. The child remained compromised. The aneurysm was taken care of. But as a child, we hope that over a period of time, he probably would show some significant improvement. Right now, he communicates with parent, but still in the bed, he has not shown significant improvement. Now, what about the fate of small aneurysm? This is something we have learned from our endovascular colleagues. Many times they show us aneurysms which has been taken care of 75%, 90%, 95% occlusion. This is something we learned from them. So if it is an unruptured aneurysm, this is similar, the vertical stacking was done, the aneurysm endovascular treatment failed. This is a fusiform type of aneurysm, right ICA unruptured. So we did the same thing like I showed the vertical stacking. There was a post-hoc residual DSS or residual aneurysm. We sat on this for 3 months. We repeat the angiogram. You see this is almost gone now. So previously, we were probably more aggressive and go back and treat it or do something else like endovascular. We didn't do anything because this unruptured aneurysm, as I said, we learned from our endovascular colleagues that sometimes this may disappear over a period of time. So this has happened in this. So we right now, if it is an unruptured aneurysm, small residual, we would follow for some time till we do something else. Sometimes a combination may be more useful, like this patient. This is a young man in his late teens with this aneurysm, unruptured, with headache and visual compromise, actually homonymous hemianopia. Failed endovascular treatment was sent to us by endovascular colleagues, again, about 10 years back. And now this aneurysm, you see there's a very short video clip there, very thick walled. There's no thrombus inside, but very thick-walled aneurysm, so no clip would sit there. So we are putting bayonet forces to hold and trying to make a clip, a neck, and put multiple, again, fenestrated clip. The typical arrangement of clip blades parallel to the parent artery and trying to preserve the carotid and preserve all the branches coming out of there. So clips from proximal to distal, distal to proximal, and from this side. And then this is the IC showing the right MCA, ACA, the ICA is pulsating there. But we had some residual which we saw, but we could not take care of that without significant risk to the compromise of some of the branches there. So we left it. So we started off with this, left with this, and this was sent back to our endovascular colleague, which was piece of cake for them to take care of this one. So sometimes this may be the better way to do rather than trying to do the last bit of aneurysm and something taking some undue risk. Now, this is a very simple technique, and this was about 15 years back. This is a type of blister aneurysm from PCOM. You can see very red, cherry red aneurysm which had burst. He had, this is a young boy with multiple aneurysm. He also had a basilar top aneurysm and 5 other aneurysms. So all these were treated the same sitting. But the idea of showing this is this very, very red, very angry, no neck, like blister aneurysms. That time I put some muscle around it and put a clip there. And subsequently, we had many discussion in many meetings and mainly with Dr. Spetzler. And he advised that it may be better to put a little bit of cotton there, which would put some fibrosis, so the recurrence risk is, and these are the other aneurysms we had, which were all clipped with the same technique. But as I said, this was some time back, and this is now. This is about a couple of weeks back in our practice. And this is a very simple technique, again presented with bleed. And he had some PTCA already. It's a right MCA, multilobulated aneurysm, the right side. Now that's the aneurysm. You can see that the branches. Now we are defining the neck. What I'm trying to show here is what I learned from Dr. Spetzler. And so this is the one component, one lobe of the aneurysm which was clipped. Could be that the bifurcation area. But there was another two almost like blebs or blisters at the bifurcation, and which was I thought was risky to clip alone. So we put some cotton slivers of cotton, very thin slivers of cotton, and clip mini titanium clip over that to occlude those aneurysms. A simple but effective procedure, which is which leads to complete occlusion, which stays occluded. So previously we used to, now sometimes we use both cotton and muscle along with that, crushed muscle and cotton. And if this is an aneurysm like this or blister or a fusiform aneurysm, then we put slivers of cotton around it to produce some kind of adhesion so that the aneurysm doesn't fill back again. So very simple and effective procedure. One of the many lessons I have learned from Dr. Spetzler over the period of time. So that's my last slide. As I said, I'm a microsurgeon, so this is a little bit of controversial but aggressive slide, but I will end with this talk. I think flow diverter is not a panacea. We have to individualize, and microsurgery is going to stay as far as I'm concerned. Thank you very much.
Thank you, Bassant, particularly for waking up middle of the night to be with us. And as you know, this session is recorded. And as we've seen in many other sessions, many people will come back and listen to this. And on the day you retire, somebody will probably take a clip from your presentation today and make fun or something. You know, God knows, there's no privacy anymore. Everything is out there. So let me open up. Let me see if the audience, well, Dr. Rossana Romani says it's an amazing session. Thank you, Rossana. Maybe I'll invite Howard and Chris to perhaps comment on your presentation, give where they agree, where they disagree. Feel free, guys, go ahead. Either of you.
Jack, there is a question.
I enjoyed the presentation immensely, Dr. Misra. I thought it was wonderful and a tour de force with some of management of some very, very complex aneurysms. I think I agree 100% that filling a giant aneurysm with coils and creating a giant mass will not alleviate a neurologic symptom and will lead to progression. Or as in the child with the big basilar tip, precipitate coma. And certainly flow diversion has a role in treatment of a lot of these things, but like any technology, I think case selection is quite important. I think one of the things that we learned with the flow diversion, as you know, we have a tremendous experience with them, is that we are one of the sites that uses multiple devices. So we'll use 2 and 3 and sometimes more devices until we see flow diversion, because then we know that the aneurysm will shut down. I think that's the only thing I would add, but I enjoyed your talk and presentation immensely.
Thank you. Jack, there is a question to me, I think, from some Dr. Andrew Chosky. The worsening of the small child was after the hydrocephalus or insufficiency. I told that we had done a scan, the shunt was working, the ventricles remained not enlarged. So it was not from hydrocephalus. I did mention that. I'm sorry if it missed. But he did not have a shunt block. The hydrocephalus was not the cause of the problem. The cause of the problem, as Dr. Riina said, was the mass of and this was way back in 2009, as I said. And those times we didn't have the other, the flow diverters in my country. I think 2009 was the time the flow diverter became famous with that Mexican work. I remember in the World Congress, we had a session on the flow diverters. This was one of the very dramatic session in 2009 World Congress in Boston, which incidentally Jack organized.
Of course, all the best meetings are organized by me, Bassan. What do you mean?
I know, I agree. I don't disagree at all. I agree.
Yes.
I agree completely.
It's fine, Basant. You missed Art Day's
I
presentation.
know.
Funny enough, not funny enough. I mean, not unexpectedly, he also stressed the parallel tandem clipping technique, 90-degree to the parent artery.
Okay, I'm sorry, I missed that one.
Yeah. Chris,
But
anything?
you said, Jack, it is recorded and is available on YouTube or something. You'll
On the
send us a
YouTube
link.
channel of our department. Yes.
So if you could, ask your secretary to send us the link
I will
somewhere.
send it to you.
Okay, thank you.
Jacques, I think that Bassan's talk was fantastic. And I think he and Howard have highlighted the fact that as endovascular devices evolve, so too does our thinking. And it's funny, you flash through cases which take, at least in our hands, a lot of discussion, thought, discussions with family, discussions with patients. And, you say, oh, I just bypassed this, but we all know that takes a lot of energy and a lot of thought. You did it really, really well. And I think even in your institution, the utilization of flow diverters continues to evolve as we learn more about them. And as Howard said, stacking them sometimes can be a really powerful tool for some of these really large and giant things. And I've even had the experience where last year, someone's vision got worse with a paraclinoid aneurysm. It was large. We talked about clipping, and when he started losing his vision after flow diversion, I thought, geez, I should have clipped it. But sure enough, we waited it out, and over 4 months, his vision came back to where it was when it started, and then continued to get better as the aneurysm shrunk. So it's sometimes, I think we're learning about this as we go, and it's fascinating. But sometimes acute decompression can be good.
So have you had, Chris, have you opened any of these cases with visual compromise? Have you had an experience with going in microsurgically and trying to decompress any of these patients who have had because of mass or?
Yeah, many times, but it's been a number of years now, because I think that was our standard therapy, in the 90s and through the 2000s, really.
No, a post-flow diverter. Post-flow diverter.
Post-flow diverters, I've only done it a couple of times. And I have also seen the situation where, I don't know if you've seen this, sometimes when aneurysm is very large, the optic nerve is very thin, and you decompress it, they actually will worsen instead of improve, and then over time improve. And I wonder if it's acute decompression changing the vascularity of the nerve that does that.
So, Dr. Riina, have you all these three cases which I showed? I haven't done anything.
Definitely, like Chris, I've operated on coiled aneurysms that patients deteriorated from, to take out the coils and clip the aneurysm. I haven't had to go and operate on a flow diverter case. I do have a couple of intrasaccular recurrences or reopening aneurysms that are going to be clipped. But as far as operating on a flow diverter, I haven't had to do that.
I have, but I obviously did not want to put a clip across it, so I just used adenosine to get proximal control. I've shown a couple of cases before, but can I use the opportunity of having Chris and Howard here? I'm going to be operating soon on a giant recanalized MCA aneurysm that was treated with the P-conus device with coils, and kept recanalizing and patients going downhill. I haven't worked on that device before. Can I put a temporary clip across the M1 where the P-conus is, and will that? It's very open cell design, isn't it?
It's very open cell. I've never used one, so I don't have any experience with it.
Same here. I have not had experience with P-conus. I've operated on a few handful of stented cases,
right.
But in those I've done the same strategy, which is I've tried to get proximal to the stent to use any proximal control, avoid putting a clip on the stent, and then clip parallel to the stent, at an MCA BIFE or something like that. Have not had experience with P-conus.
I looked at the picture of it and I saw it's very wide open cells, so I'm assuming.
Yeah, it's not a lot of metal. I think the stuff that's in the parent is an anchor.
Yeah. Are you
Okay.
thinking of bypassing it, Jacques, as well?
Yeah, oh, I'm bypassing it. It's a
Yeah.
massive thing, and I lost my opportunity to clip it. It should have been clipped originally, but it was done elsewhere. So I might trap it, distal to the perforators, and I'm thinking if I close on the P conus, will the metal come together and occlude a lenticular striate? Probably not, but anyway,
Right,
we will
right.
we'll find out. Anything else? I don't have anything else from the audience. Everybody's saying it's an amazing session. Dr. Bassant, you have the last word of the last session of my series. Whatever you'd like to say, and then we'll close after that.
Thank you, Jack. Thank you. It's had been such a year, 2020.
Yes.
By the way, I mean, you have probably some idea because you spent time in UK. 2020 is a very popular cricket game in the Commonwealth countries.
I did not know that. My wife would know that.
Yeah. So I thought you would spend some time in UK. You would know cricket about a little bit. But
Yeah.
this is a very popular, game like your baseball in your
Right.
country. Cricket is kind of everything stops when you're playing cricket. So we are doing now, everything is stopped. They just restarted 2020, and without any people in the stadium, and it's all on the television, and they're getting a lot of money with that. But
Right.
I hope 2021 will be better, and we will meet in person, and that will be going back. But one thing we have learned from this pandemic, the couple of things which we have learned, which has come out good actually, is number one, which is this video conferencing, the web meetings, which has been very useful, actually much more larger reach than any physical meeting would ever happen. I mean, so I think the future is going to be a hybrid meeting, as far as I'm concerned. I'm a very active meeting guy. I mean, I do a lot of meetings over the years. You have been to many, but that's going to change. That's number one. And number two, in my practice, as far as the doctor-patient relationship, something which has changed significantly, at least in my country, I don't know what's happening in yours, is tele-video consulting. Many of these patients, because India is such a huge country, people travel thousands of kilometers to come for a 5-minute consult and go back with 3 people, spending money, spending time. That's going to change.
Right.
I think we're going to continue that. So these are some of the things which have come out good from the pandemic, but otherwise that it's been a disastrous year. And I hope it ends soon. And you people guys, be safe, and we meet maybe 2021, hopefully.
All vaccinated.
Yeah.
Howard, Chris, and Art, if he's listening, Bassant, and the audience, wonderful. Thank you so much.
Thanks, Jacques.
Bye,
Thank you
everybody.
very much.